we're going to begin this last section talking about schizophrenia. Let me see if I can get to the right page on the PowerPoint. There we go. So we talked about anxiety and mood disorders and somatization disorders, which are very interesting. Schizophrenia is considered a disorder of thought or cognition. It's characterized by severely impaired cognitive processes, personality disintegration, and social withdrawal. So they group the symptoms of schizophrenia as positive and negative symptoms. So the positive, and I don't think they mean like good and bad. That's how they've named the symptom group. So the positive symptoms of schizophrenia are delusions and bizarre behavior, and the negative symptoms are flat emotions and decreased speech. So you can see really how both of those symptom groups can contribute to social withdrawal. General symptoms include disorganized thought process, impaired communication with inadequate language skills, that also contributes to social withdrawal, and delusions or false beliefs and ideas. So specific schizophrenia symptoms include that with delusions, which are false personal beliefs, firmly and consistently held despite evidence or logic. Unfortunately, that sounds like a lot of people who are currently in office in our government, which we don't even want to talk about that, but delusions of grandeur, delusions of control, delusions of thought broadcasting, where you can like push your thoughts out to other people, delusions of persecution and paranoia, and delusions of reference. So a lot of times that delusions of reference, like you're projecting something onto somebody else, something with your own behavior, and you're accusing somebody else of it. So those can be very isolating symptoms, obviously. Hallucinations are also characteristic of schizophrenia. Hallucinations are sensory perceptions that are not directly attributable to environmental stimuli. They can be visual, olfactory, or auditory. So a lot of times people with schizophrenia will say that they hear voices talking to them, or they see things that aren't there, or smell things that aren't there. So there's also disorganization of speech or thought. So that can result in tangential speech and loosening of associations. So just not being able to connect the dots on things. And disorganized motor activity as well. It can be extreme. So high levels of activity or low levels to the point where the person is catatonic. So there's a variety of symptoms that are different in each individual. But when they start looking for the etiology of schizophrenia, the common changes that they see in people with schizophrenia are reduced gray matter in the temporal lobes, enlarged third and lateral ventricles, and that's the areas where the cerebral spinal fluid is stored, abnormal cells in the hippocampus, and that affects memory and memory storage, excessive dopamine secretion. So I went to a really awesome lecture with a researcher from the University of British Columbia talking about dopamine disorders. So dopamine disorders include schizophrenia, but they also include Parkinson's and ADHD. With schizophrenia, you have excessive dopamine secretion. With Parkinson's, you have diminished dopamine secretion. And with ADHD, you have diminished control of dopamine. So the researcher that I went to the lecture with was talking about with ADHD, so you have a bunch of sensory stimuli hitting you from all directions all at once. And in order to pay attention to any one of them, you have to have a spike of dopamine to pay attention. So the medication that's used to treat ADHD actually increases activity so you can get better dopamine spikes. For Parkinson's, you have decreased dopamine secretion because the cells that are creating dopamine in your brain are actually dying off, the neurons that create dopamine. And so you get a dysfunction there's a sensory, cognitive, and motor disconnect, and so it's hard for them to organize motor activity. There are also some cognitive effects as well, and we'll talk way more about Parkinson's next quarter in neuro. So with schizophrenia, you have excessive dopamine secretion, so you have excessive sensory input. So that might contribute to hallucinations. And there's also decreased blood flow to the frontal lobes. So the frontal lobes, that's the executive area of our brain. That's where we're making decisions, where we're making discriminative decisions. And so decreased blood flow is never good, right? Things don't function as well without blood flow. So the theories of the etiology include a genetic predisposition and brain damage in the fetus. So someone who has schizophrenia, even though it doesn't develop until later on in their teen years, they probably already have it. So the treatment is antipsychotic drugs. There are frequent side effects with antipsychotic drugs related to excessive extrapyramidal activity, and that's an area in the brain. Involuntary muscle spasms in the face, neck, arms, or legs, which is dystonia. Chewing or grimacing. Repetitive jerky or writhing movements, which is called tardive dyskinesia. And sometimes the side effects can be reduced by anti-Parkinson's agents. So anti-Parkinson's agents try to increase the level of dopamine. The antipsychotic drugs, I don't know specifically how they work, but I imagine they have something to do with dopamine metabolism. And so maybe the anti-Parkinson agents are trying to balance that out a little bit. Usually there's psychotherapy and psychosocial rehabilitation. Lots of people with schizophrenia have difficulty functioning in normal life, as you can well imagine. So I have a good friend who has a sister who's got schizophrenia, and she was diagnosed in her teens, and for a large part of her 20s and 30s, she was out of contact with the family. For some of that part, she was homeless. My friend was eventually able to contact her sister and get her into a good treatment program, get her into a better living situation, which is great. So having good family support or some kind of support can be really important for these people, but they might never be able to function on a normal level. So now my friend and her sister are in their 70s, and when my friend and her husband were writing their will, they worked with someone who specializes in inheritance for people with disabilities. Basically, you want to make sure the person's taken care of, but you don't want to give them so much that they lose their disability benefits. That makes sense. And so they worked with a specialist in that so they could make sure that if both of them were to pass away, that her sister would be taken care of. So it's really great that she has that good family support, but not everybody has that. So it can be a really isolating and seriously life-affecting disease. So cognitive disorders are disorders of thinking processes, memory, or perception due to transient or permanent brain dysfunction. So the cognitive disorders that we're going to talk about include dementia, and we'll talk about some different causes of dementia. There's starting on page 376 in the text, there is a really nice section on dementia and different types of dementia. Dementia is definitely permanent brain dysfunction. It's progressive and it does not go away. Delirium, on the other hand, is a transient brain dysfunction that can be a result of trauma or medical procedures or medications. Brain trauma or organic brain syndrome can be transient or permanent, depending on the effects. A lot of times, again, this is another thing that is often treated with antidepressants. And then there are some condition-specific medications for dementia and some of the organic brain syndromes that are used for treating these cognitive disorders. So dementia is a decrease in cognitive function that's characterized by aphasia, which is disturbance of language, apraxia, which is inability to carry out a motor activity, and agnosia, which is inability to recognize objects or people. So in the book, they talk about how it's there are lots of different dimensions, but usually lots of different definitions. Of dementia, but it's usually it's a progressive chronic disease in which cortical function is decreased. It impairs the cognitive skills like language and numeracy, which means they can't comprehend numbers. So the interesting thing about Alzheimer's and some of the other forms of dementia is they have an insidious onset. They don't have a sudden onset. And so sometimes the manifestations start pretty small, and it can have big effects on people's life, like not being able to deal with finances and numbers. That can cause a lot of problems. Eventually it gets to the point where you realize that there's something there's something bigger going on. One of my good friends, her father had Alzheimer's, and in the early stages he just seemed a little forgetful, and it would be sort of things like they were visiting and they went to the Museum of Flight, and he was aghast that it cost $20 to get in. So he sort of had this affect like he thought it was 1945 on things, and he'd go to the grocery store and be just shocked by the prices because he was expecting prices from 1945 or something. So but that wasn't so disruptive, and his wife was there to kind of make up for a lot of his deficits. So it wasn't till he became severely affected that he was diagnosed, because he could kind of get along with the memory issues, and he didn't have very many motor effects as of yet. So kind of interesting because of that insidious onset. So there are cognitive tests that they do, that doctors and other healthcare professionals do, to distinguish between what they call normal forgetfulness and then memory loss related to dementia. One doctor I heard said, if you forget where you parked your car, that's normal. If you forget that you have a car, that's Alzheimer's. So, simplistic, of course, but there are lots of other causes for dementia, like vascular disease, infections, toxins, genetic disorders, normal pressure hydrocephalus. Advanced Parkinson's disease can result in dementia. So Alzheimer's disease accounts for about 50% of people affected with dementia. And vascular is in second place from Alzheimer's. So there's a really great little exposition of Alzheimer's in the book, and probably we will, in physical therapy, we'll see more people with Alzheimer's than just about any other kind of dementia, just because of its prevalence. And I took a really awesome course several years ago at the Infinity Symposium on working with people with dementia in physical therapy. And one of the things that that's characteristic is they kind of lose their abstract thinking and problem-solving abilities. That's characteristic in Alzheimer's. And so you cannot give people really complicated multi-step cueing. When you're trying to get somebody to do something, the simpler you can keep the cues, the better. So if you walked into somebody's room who is fairly impaired with dementia, and you said, okay, we're going to get you out of the bed now, let's have you get up and we'll put your shoes on, blah, 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 they are probably not going to respond well to that. But if you say, Bob, sit up, he does it. And you go, okay, now stand. He'll do that. Sit in the chair. He does that. So one-step cues are more effective for people that have difficulty with problem solving and abstract thinking. Sometimes after different neurological events, people might have motor planning issues, and that's a little bit different. And then we'll talk about that a lot next year in your neuro rehab class, how to deal with motor planning issues. But with dementia, people need one-step, short, to the point cueing because they lack the ability to problem solve and perform abstract thinking. But a lot of times, once you get somebody going on a task, they can do really, really well with it. There are also different levels of cognitive impairment, and people at different levels can be expected to be able to accomplish different things. So people at lower levels of cognitive ability just are unable to do certain tasks. Like it's difficult for them to learn a task and then extrapolate it to a similar task. So you might be working with someone on transfers from a bed to a chair, but then they can't extrapolate that to transfers from like a wheelchair to the toilet. So you have to work on each task in isolation because they have the inability to extrapolate and do that abstract thinking. So it's very interesting. The other thing that I learned in that same workshop is that people below a certain cognitive level have the inability to pay attention to things at their feet, so they might trip over it. They only have a very limited window of attention, so while they might be able to perceive something, they just lack the ability to pay attention to it. So a very interesting aspect of dementia. So delirium can often present a lot like dementia. So it's impairment in consciousness with the reduced ability to focus, sustain, or shift attention. Doesn't that sound like what I was just talking about? But the difference with delirium is it's transient. It's not progressive and chronic. So it can be caused by certain medical conditions, like if somebody has septicemia or an adverse drug reaction, or sometimes substance abuse. Delirium can be a result of that. However, the person normally recovers once the medical condition is resolved, the drug is out of their system. They can get back to normal. So at the hospital that my clinic is associated with, they have a geriatric fracture protocol, because frequently with delirium is associated with geriatric fractures. Sometimes it's associated with the medications that are given in the emergency room setting. Sometimes it's associated with just the trauma and other things. So they have a specific protocol for geriatric fractures, which is different from non-geriatric fractures to help avoid delirium. Because that can be a safety issue and a real scary and problematic situation for someone. So brain trauma or organic brain syndrome, they can be short-term or lasting cognitive effects as a direct result of trauma to the brain. So it can cause confusion, memory loss, irritability and agitation, and attention deficits or poor concentration. So a lot of times they're caused by concussion, contusion, or laceration of the brain. So sometimes when you're working with someone right after a brain injury, the attention deficit and poor concentration, as well as the memory loss, can make it super hard for them to perform tasks in physical therapy. And so it requires a lot of patience and a lot of flexibility on our part. So it can be a super challenging patient to work with. So the last thing we're going to talk about in this section is eating disorders. So eating disorders are basically behavior characterized by physically and or psychologically harmful eating patterns. So the two we're going to talk about are anorexia nervosa and bulimia nervosa. The treatment for most eating disorders is nutrition, proper nutrition and nutritional education, antidepressants, used in a lot of disorders, and a lot of times eating disorders are treated in inpatient treatment centers. Inpatient treatment centers tend to be more effective because you have control of everything in that person's environment, and with eating disorders, that is an important thing. So anorexia nervosa, in the digestive chapter and some of the other chapters, we talk about anorexia as a symptom, and anorexia without the nervosa, just anorexia, means loss of appetite. Anorexia nervosa is the disorder is an intense fear of becoming fat and engagement in self-starvation. And it usually is characterized by body dysmorphia, where people are unable to objectively assess their own physical condition. So we might look at them and say, wow, you are skinny enough to be skeletal, and they look at themselves in the mirror and say, no, I'm not, I'm fat. Or, if I eat 1 ounce of food, I'm going to get fat. So there are a lot of physical complications to starving yourself, not the least of which is cardiac arrhythmias due to electrolyte imbalances. So we learned way back last quarter about how hypokalemia, lack of potassium, can cause cardiac arrhythmias and even cardiac arrest. So that's a huge, big deal, right? Bradycardia is a slow heart rate, and hypotension is low blood pressure. So there are two different types that are classified: restricting, meaning they completely restrict the amount of food intake, and binge purge, where they eat and then purge either by vomiting or use of laxatives or diuretics to get rid of food and fluids. The psychiatric complications of anorexia nervosa can be guilt, depression, and anxiety. I saw a really interesting program a while back on anorexia nervosa and eating disorders, and they were talking about there can be a biochemical effect of self-starvation. You get to a certain point, and there's actually it actually engages a reward cycle in the brain. The starvation, the physical effects of starvation start to trigger neurochemical changes. So really interesting. So bulimia nervosa is characterized by binge eating, and everybody has. Some people binge eat at least once a year on Thanksgiving, where you eat way more than you should. But the difference is you have control over that. You only do it on Thanksgiving. Well, you probably shouldn't do that either. But with binge eating, it's at least 2 times per week over 3 months in order to be classified as bulimia nervosa. And the person feels a loss of control over their eating. And they use inappropriate means to control their weight, like laxatives, vomiting. Exercising to excess is a particular subtype called exercise bulimia, where people will eat, but then they feel that they have to work off every calorie that they ate, and they will exercise to the point where it's not good for them. And fasting is the other inappropriate means to control weight. So the physical complications, particularly with the vomiting, are erosion of tooth enamel and esophagitis, because the esophagus gets irritated from the vomit, and decreased potassium with the cardiac arrhythmias and cardiac arrest as a potential of that from vomiting. So in terms of presentation, someone with anorexia is going to present as extremely thin, to the point where you can see all their bones, and nervous and agitated a lot of times. The person with bulimia presents in a more normal way. So they usually don't have that concentration camp look. They're controlling their weight using inappropriate means, but they're not starving themselves. So Both of them can be very serious illnesses. One of my sister's good friends from high school that she's still good friends with had bulimia when she was young, and she got good treatment for it and learned to control her eating and control her nutrition, and she grew up and lived a happy life. So it obviously can be cured.